Support for To The Point comes from Bausch & Lomb.
Beautiful and healthy looking eyes? It shouldn't be a compromise. Lumify Eye Illuminations, developed by the experts at Bausch & Lomb exclusively for the sensitive eye area. To cleanse, nourish, and brighten. Lumify Eye Illuminations, only in the eye care aisle.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hi, Jessilin. What's up?
Hi, Jackie, and hello to all of our listeners. Today is so exciting. I feel like I say that every episode, but I really love our guest today. He's an innovator, and he is a healthcare professional, a retina specialist. And so, what are the odds that we would have a really rock star retina doc on an ocular surface disease podcast?
I know.
Who would have thought of all things? I mean, literally, I also was asking that question myself today too. But here we are.
What are you doing here?
Well, listen, I ask myself every day that question, and I don't know how it came. I mean, yeah, it's great. I love it. Although I will tell your listeners, my voice is not nearly as calming as either of yours, because that intro was so calm, and then mine is extremely not calm. And this is probably not the podcast where if you're listening to it on 1.5 speed. So this is not the one.
I was just going to say that. So first of all, listeners, please welcome Dr. Srinivas Kondapalli. Okay, we should probably introduce you, Srini. Okay,
yeah, that's true. Yeah, fair.
So Srini's a retina specialist. He practices in Pennsylvania. He is incredible. And our paths have crossed now a couple of times, and every time it's so enjoyable to talk to you. But I was totally going to tell the listener, if you're on 1.5 speed, you're going to want to not do that for Srini, because he talks very fast. So just put it on normal speed, and then you'll be good to go.
But I feel like for as fast as he talks too, I feel like his brain must be 3 times speed. But honestly, that's probably because you just think at this fast pace, you're able to keep a retina schedule, but then also able to think outside the box and create these new products that are helping patients, helping eye care providers.
Yeah, it's interesting you say that. I sometimes question if I should have done retina or what else I could have done. And it's funny, I didn't really know why I became a doctor or an ophthalmologist or a retina specialist. I mean, I didn't know really what else to do. So that was kind of an interesting component of it. And I think I kind of was drawn towards retina because it was relatively fast paced.
So what's interesting about you for this particular podcast is that you are a retina specialist, and all we talk about is ocular surface disease and dry eye.
Yeah.
So I would like to know, we're here to talk about Rinsada, which is your product. And can you tell us a little bit about what this is? How on earth did a retina specialist come to think of this product? And give us a little background.
Sure. So, obviously, if you've ever seen a note from a retina specialist, one of your patients that gets back, they all either have a clear cornea or SPK, and that's it. And they all have 0.3 cups, right? So that's pretty much, and then everything else is BASLAT. So, it's not I love ocular surface by any means. It's not that I'm very good at ocular surface or cornea. It just never really clicked for me. I didn't really that part of the eye just never really grabbed me. I just never really found it interesting. However, in retina, you deal with a lot of ocular surface because obviously we do injections all day. So 80% of my practice is giving injections. And so in injections, the injections don't hurt, but when you talk to patients, or patients basically scream at you after the injection and say the next time you see them, they'll say, hey, the injection was fine. It just, my eye felt terrible afterwards, right? And they all tell you that. And it's really obvious because the betadine, or the soap that we use, it's really effective as an antiseptic. However, it's really toxic to the cornea, but it's really good. It obviously kills any bugs, prevents you from getting an infection. So, doing injections, usually the way I do mine is that I, do the shot and then my technician will rinse them afterwards. And um, as I leave the room, usually I do the shot and I leave, right? And the technician's rinsing them. The patients would always say like, "Hey, can you rinse me really well? Just give me a good rinse." Or, "Hey, can you make sure that this technician is rinsing me instead of this technician?" Which is like, okay, a little bit odd. Or they would say like, "Hey, rinse underneath my eyelid. That's where it gets all stuck." But then, realistically, kind of hearing that over and over again, it kind of made me click like, hey, there's probably a better way to do it, right? Because like engineering wise, you kind of have to engineer a way to give a good rinse because, when you're rinsing out the soap, there's going to be some limitations, right? Like obviously your lid's covering your eye. If you're a squeezer, that'll prevent good rinsing. You have a really deep set lid. And so patients would ask for a really good rinse, but also, squeeze the entire time. So that made no sense. So that's kind of how the device was designed. That was kind of the impetus to create the device. And then we did an initial trial where we just basically asked injection patients. And originally, I just thought it was going to be for injection patients, right? Like, I never really had this aspiration to create a dry eye or ocular surface disease device. But in our initial trial with injection patients, we just asked them these like free form questions at the end of the trial, and the questions were just like, "Hey, do you have any feedback for us?" We're just trying to figure out like, "Hey, is this a useful product to kind of pursue? Is it really beneficial? We understand anatomically that it is providing a better rinse, but like, is it actually providing a better patient experience?" We found that yeah, it definitely was, but patients would also say like, "Hey, I didn't have to use my artificial tears as often. I was able to read a lot easier day of a day after my injection," which we knew were kind of the secondary endpoints for some of the I'm pretty sure Xiidra clinical trials. One of them are Restasis. Restasis. Restasis is the first one. Yeah, Restasis. Right? That's the first. That's the original, right? The OG dry eye drug. Um, and so that's kind of where the impetus was to kind of look into ocular surface disease. So that's kind of the really long story in terms of how it kind of developed. And then we pivoted into more into ocular surface disease when we read and looked into other studies that looked into rinsing. Because, in residency and stuff, we always were taught like, hey, rinsing doesn't do anything. It's actually not that useful. It doesn't really, it's actually somewhat can be even negative. But what was interesting is that other places, not only in the US, but in the world, we're actually looking at rinsing and found it to be actually kind of beneficial. Not only did patients feel better, but it actually reduced MMP9 pretty effectively. And so that kind of spurred this interest to see if this could be done for the device, right? Like basically look at MMP9 as an endpoint. That's kind of what we looked at in the clinical trial, and that's kind of what we saw. And we ultimately found that it did kind of improve patient symptoms, had this reduction in MMP9. That's kind of how it kind of grew out. And that's kind of where we are now.
So I have a question about when you guys were doing the rinse initially, were you doing that different than what you ended up developing? Because really Rinsada is an actual device that comes packaged with, syringes of saline. And so there's an actual sort of device that helps kind of retract or get underneath the lid there. So how did that come from you probably didn't have that when you were first doing the rinse. So how did you kind of come up with that, and what's the benefit of doing that, like really kind of getting that water, projecting it underneath that upper lid into that sort of fornix area?
Yeah, exactly. So, the initial kind of design, I sketched it out on a piece of paper, and I remember Jeff, my husband, was like, "You're losing your mind." Like, this was like the point where he was like, I'm pretty sure that like you've lost it. Because I like have the original patent actually, it's like on the original provisional patent rather, it was like on this like piece of scrap paper that we submitted to the U.S. Patent Office, and it looks nuts. Like the drawing looks absolutely like a crazy person, but um, a long, long time ago, when I was a resident, I had done a lot of research in plastics, oculoplastics, or actually when I was in medical school, rather, I did research in oculoplastics because I thought I wanted to do plastics at a time. And so I was really familiar with a lot of the plastics tools. So, like, there was this one called the Demar retractor, which you use a fair amount of time in traumas. And Demar retractors are really nice because they work basically in every eyelid, right? And that's the measure of a good tool is that it should work pretty much for every patient, right? And it should do one thing really well. I kind of describe it like a kitchen gadget. So like if you ever had that OXO, not OXO,
Yes.
yeah, OXO
Yeah.
has a
Yeah.
lot of
Yeah.
kitchen gadgets, right? And if you ever watch like America's Test Kitchen, they like review kitchen gadgets, for example, and they say like, and there's also this like YouTube video or YouTube guy who's an engineer who rates kitchen gadgets and like basically says like why this kitchen gadget is good or not. And so what's interesting, a good kitchen gadget only needs to do one thing really well, right? And it should just do that one thing really well every single time, regardless of what type of thing it is. So for example, like there's this OXO avocado like peeler, where it has three components where you cut the avocado, you deep hit it, and then you can slice it. And it doesn't matter what avocado you have, it will work for every type of avocado, right? And it does one thing really well, which is just basically, get rid of the stuff or basically provide you an avocado. And that's the same true with medical devices, that a medical device realistically should work for like 99% of patients and should do one thing really well. And that's what I was kind of aiming for, was to provide that thing that worked in every type of patient and worked, really well. And so, the question was like, oh, why didn't you think about like just using, instead of a retractor, using a speculum? Patients hate speculums. Speculums are very dependent on certain types of patients' eyes. So like, um, if you have like certain speculums you can't use on patients, right? Like, so even in us, like sometimes I have to use a baby speculum on certain eyes versus like a standard speculum, and so it doesn't really work. Retractors are good because, technically we're for 18 and older, but like in theory, if you had a baby eye, it would work. And then if you had an animal eye, it would also work too, because basically you just need a lid and the tissue underneath. And so like that kind of knew that like, okay, that a retractor was probably going to be the better of the options. Probably getting off topic. But
I mean, we were talking about avocados at one point.
yeah,
I
yeah, yeah. No,
think
no, that's okay.
we're good.
It's yeah. I think we're still in the right frame of mind. And so the concept behind it was that, listen, all the stuff gets trapped underneath the eyelid and in the fornix, right? Like, so when we put the soap in, it gets all trapped underneath there. So how are we able to actually get underneath there and just rinse that out? That's all we're trying to do. And like anatomically and kind of evolutionary, the lid protects a lot of important things, right? It's basically protecting your cornea and the bulbar conj, but also that lid structure really protects like the conjunctival, or the fornix protects the lacrimal glands, main ducts, and then the conjunctival, the palpebral conj has a lot of really important inflammatory cells that happen to be there to kind of trigger the inflammatory cycle. And so that stuff is all really useful, but then when stuff is in there that's not supposed to be, like soap, and then obviously like environmental stuff, high allergen load, inflammatory load, then it kind of dysregulates and it's really hard to get to. So like, how can you just get to the area and get rid of all that stuff? And so that was kind of the first thing, is that I wanted to work for basically any type of patient. And then the second was that the point of the jets were that we knew that it had to be at the right kind of a certain level of PSI, because you need to be in the right level where it has to be strong enough to get rid of the like junk. And the junk at the time was the betadine, because betadine can be actually sticky. Like if you ever put it on your fingers and let it dry, it can get sticky. And you can see it on patients' eyelids. Like it'll just get sticky when it sits there. But two, it couldn't be too high where it would cause damage. So sometimes if you like water pick really hard or like into your gums, it can cause them to bleed. And so you don't want that, right? Because you obviously don't want the patient to bleed. So we knew we had to be in this right PSI, which incidentally also was the PSI that's actually pretty effective in removal of biofilms, which we'll get, which we can talk about. But so we knew kind of those were the two kind of parameters. And so realistically, I knew retractors worked well in that regard. I knew that we had to be at the right PSI. And so, that kind of worked in the way that I originally thought about it, was maybe a little bit different than the final product, but we kind of knew those two things had to be there. And the rest of it, the manufacturing processes kind of changed it a little bit. But those were the two things that we thought of for sure.
I love it. I do think this device is very comfortable for patients, right? You're exactly right. It is the perfect kind of pressure of a stream to do its job, but it is very gentle at the same time. It's very well tolerated by patients without even having to, use kind of a topical anesthetic. So we've talked a little about how it's helpful in the retinal world, and we've kind of briefly touched on it in the ocular surface disease space. But for reducing MMP9s, for maybe kind of our very allergy prone patients, kind of cleaning out those pollutants that might be in there. We've touched a little bit on biofilms. Those are kind of three big areas of why it is kind of a perfect fit for the ocular surface disease patient. So with biofilms, you've obviously studied this, because you kind of alluded to there's a certain amount of pressure in order to get rid of that. So what have you found with Rinsadas in relation to kind of biofilms on the front surface of the eye?
I think biofilms are super fascinating. I think that there's been a huge focus in terms of biofilms on the ocular surface, and especially its relationship to dry eye disease. And I think it makes sense, right? Like I think that there's definitely this really strong relationship between ocular surface biofilm and dry eye disease, where it probably just gets dysregulated. What's interesting, though, is that a lot of ocular surface biofilm focuses on the anterior component, which is like lashes, meibomian glands. And those are fair, right? Like there's obviously blepharitis that people can take care of with blepharoexfoliation. Exfoliation. You can heat and express the glands, and that's really good. And I think that there's a lot of products out there that kind of do that in different mechanisms, right? In different mechanisms of action, whether that's, a chemical component or enzymatic component, or if it's a mechanical component that's actually removing the biofilm. Heat and expression is a mechanism as well. Regardless, that's great. It's fantastic. But what's interesting though is that the biofilm doesn't stop at the lid margin, right? Like it just doesn't. But in our minds, it really does. For some reason, when we think about therapeutics, we really have this kind of fence or barrier that the biofilm stops at the lid margin. But if you look back on the original papers on biofilms and ocular surface disease, they talk about how it really moves into the palpebral, conjunctiva, and fornix, and that's an area that we completely forget about. And part of it is because we don't see it, right? It's very satisfying to obviously take care of blepharitis because you can see the blepharitis go away. And it's very satisfying, obviously, to heat the glands and express them because you just see all this gunk getting removed. With this, it's like, it's not super satisfying because, you don't see it, but also like when you flip over the lid, like it's also impossible to flip over the lid and no one's looking in anyone's fornix, right? Like that just doesn't exist. But it's really interesting. The fornix especially houses this probable really interesting like microbiome environment in which the biofilm probably moves past the meibomian glands up into the palpebral, conjunctiva, and fornix. And that's where it becomes really problematic because that's where it starts invading the ductules of the lacrimal gland. And so this is I had to kind of think about really like basic anatomy stuff was that the lacrimal gland is an exocrine gland. Exocrine glands have to have these ductules. Ductules basically are these little like tubes that allow the aqueous or the aqueous component of the tear to kind of dump out, and they dump it in the superior conjunctival fornix, right? But those ductules actually get fibrosed in patients that have dry eye disease, and that's what they looked at in postmortem studies, is that those ductules get fibrosed. And so it suggested that there's high amounts of inflammatory load as well as like fibrosis in the fornix that's really contributing to why patients often will have like SPK or aqueous deficiency component of the dry in addition to blepharitis or meibomian gland dysfunction. So, I think the biofilm aspect is really interesting. But obviously, with biofilms in the palpebral, conjunctival, fornix, you really can't do necessarily chemical or really hard mechanical removal of that because it's a very tender area. But water or kind of hydro removal is one mechanism to remove biofilms, and we do that all the time when we go to the dentist, for example, when they use that like water pick for the plaque on your teeth. It's the same kind of phenomenon. So in that situation, you have to have the right psi, and I think it's between 8 and 11 or 8 and 12 psi. And that's what we essentially do, is that we're kind of hitting at the right psi in order to, in theory, remove biofilm that's kind of sitting in the palpebral, conjunctiva, and fornix. So I think the way to always conceptualize it is how do you describe it to the patient, right? Like, so let's say, you're talking to a patient, you're talking about Rinsada, and you're already doing some sort of biofilm removal. I think it's a pretty straightforward concept is you say, hey, listen, we spent a lot of time cleaning the outside of your lid with like blepharoexfoliation exfoliation or with meibomian gland expression, which is great. But we also need to clean the inside as well because it didn't stop there. It continues on and goes. And so really we're going to clean the inside and out, and that's kind of how we're going to accomplish it. And the way that patients and physicians rather are using it are they're doing kind of their outward or their anterior cleaning first and then doing Rinsada at the end. And usually patients feel better before they leave because oftentimes, I've had other stuff, like I've had, blepharoexfoliation exfoliation done to me and I felt like terrible afterwards because they probably just released this huge inflammatory load on the ocular surface. And so they kind of do that instead so that, they do it afterwards just to make them feel better. And that usually works pretty well in kind of combination.
Support for To The Point comes from Bausch & Lomb.
Beautiful and healthy looking eyes? It shouldn't be a compromise. Lumify Eye Illuminations, developed by the experts at Bausch & Lomb exclusively for the sensitive eye area. To cleanse, nourish, and brighten. Lumify Eye Illuminations, only in the eye care aisle.
I know in your studies you talked about, seeing a decrease in MMP9 scores and hearing about patient comfort. Is there a particular patient that is it just our dry eye patient? Is it just our allergy patient that we should be thinking about Rinsada in? And how often should we be doing that in your opinion?
It's a good question. I mean, I think that realistically, you have to think about when a patient comes in, obviously we did MMP9 for the study because we need an objective measure, right? Like, because otherwise there's not a ton of great objective measures in ocular surface disease for us. Like especially for a study of our size where it was small, multi-center or multi-site study, but we also had some logistical issues, right? Like we can't necessarily have, like not every center had like an anterior segment photo or a camera to like do staining necessarily, or, and we know other studies had looked at MMP9 to show the results, so we knew that it would probably be a positive result for us. That being said, I don't think it's necessarily one of those things where, you have to do MMP9 before you do Rinsada, right? I don't think that that's necessarily the case. I think you just have to think about it logically, like, right? So if a patient comes in and they're symptomatic, right? Like their eyes feel crummy, they're having complaints, and we hear those complaints all day, right? Like they're burning, stinging, itching, irritating, tearing, stuff like that. You and I both know that they have probably a high inflammatory load on the ocular surface, and whether that's high MMP9, high lactoferrin, high IgE. It's, one of those, but they're high. The idea is that the patient that coming into you that's symptomatic has this probably high inflammatory load. And so realistically, their tear film is infiltrated with high inflammatory load, high allergen load, high microparticulate matter, which is really actually a very kind of side note discussion about this whole thing that we really don't pay much attention to in ocular surface disease, which we might want to get to in a second, is microparticulate matter and like the environmental impact of ocular surface disease. Anyway, so all those patients, all that stuff is sitting on their tear film, right? And everything we currently do helps reduce further inflammation. So, like, obviously, I love a good steroid, right? Like, I love a Pred Forte. I love to prescribe it. It just makes my life so much easier. Even for Pred Forte is great. I mean, I love it, makes everything easier. But the problem is that for ocular surface disease patients, like, you're really not helping them in that regard because you're helping prevent further inflammatory load or further inflammation, but you're not doing anything with what's sitting there right then and there. And so that's why I think there's a degree of dissatisfaction with the patient, because there's this great study out there that says that 83% of the time patients want treatment that works within 5 minutes. And when they come in with flares, they're not getting that, right? Like we don't really provide them with that. And so that's an opportunity or missed opportunity there where we could really kind of help reduce their inflammatory load before they leave. So, I would say, especially for the physician that's starting out, do it conservatively on the patients that are complaining with, really common dry eye complaints like allergic conjunctivitis, really classic itching, really classic dry eye disease. And what you'll find is that I think that you'll get the positive feedback loop, and I think that we're finding this out a lot from physicians that have incorporated into their practice, is that the positive feedback loop helps, right? Is that the patients feel better, then you're like, oh, this is doing something, so you're more confident and want to try one more thing. So that's what I think we're finding is that as physicians get more comfortable with it, which takes time, and I totally understand that, you'll grab for more kind of uses. And so, for example, we did one recently. We're hopefully going to present it soon, where it's a patient with mucus fishing syndrome, which was disgusting. But then we did it on her. Essentially, we cleared the mucus fishing. A week later, we have a week, and we're running up the month data soon, where it's like essentially the mucus fishing has stopped, which is good. And it's probably because some of that helped clear the initial mucus, and then it's kind of helping clear the other stuff as well. So long story short, I think that realistically, the patient to start it on is the patient that's complaining with ocular surface disease or dry eye disease complaints, and allergic conjunctivitis is the other one. In terms of how often to repeat, there's two different models. I would say that the first model is more like a dental model, where they come in on a Q4, Q6 regimen, where they're like, oh, just like a dentist, I'm going to come in and get that cleaning, whether it's a blepharosphere exfoliation plus Rinsada or gland expression plus Rinsada, or sometimes they're doing it after every IPL as well, and considering that with that. And the other model is that, hey, just let's do it on a as needed basis, right? Like, so when you are flared, that means that obviously, your baseline dry eye disease is worsening. You have really high inflammatory load. Let's get you kind of kickstart this inflammatory load reduction, and then get you home on whatever we need to go on. And that you kind of the two pathways to think about it. But just, I mean, you've used it, Jessilin. What is your, like, what was your first patient? Because I'm always curious about, like, knowing that.
Yeah, it's been great. And I still think my use for it is evolving. So I initially had brought this in for my initially kind of allergy patients. I wanted them to be able to have something in the office that I could start kind of jump starting that, getting them feeling better. And then, maybe still using a topical drop of some sort, allergy drop, topical steroid. But it was finally something that we could do in office. And then from there, it's really kind of evolved into, you just start looking at that biofilm kind of explanation that you did a lot differently. And so a lot of my patients that I know have even like a ton of ocular rosacea, a ton of blepharitis, like I'm adding that in after we clean up the lid margin, and it seems to work and help. This past week, I did somebody that had a graft versus host, and so just
Oh, no
that was
way.
yeah. And so because I just wanted to kind of try and see, and it was immediately he was like, "This is the best my eyes have felt." We didn't do a topical anesthetic, and so I think I'm a fairly newer adapter to this, but it's like my mind is just now going of all the different applications with different patients. And if there's more tools to be able to help our patients, like that's a win-win. And to be able to have something that takes very little chair time, it doesn't, and I love the Rinsada kits. We haven't even really talked about that, but it doesn't take a lot of It's not a huge investment. It doesn't take take up half your office space to store this or another piece of equipment. And it gives immediate relief to patients, which is really great. So these kits, so
Oh yeah,
for,
for sure.
physicians out there that maybe haven't seen Rinsada or want to bring it in, talk a little bit about that. Like how does their practice purchase it? What is the kit? Have you used any clinical pearls that you've seen physicians? Because, like with anything, you just get better at it when you get more hands-on experience. What have you seen?
Right. Yeah. Yeah. Okay. So let's talk about that. I mean, I think that, yeah, so the kits are pretty straightforward. Essentially, it's a kit that's basically a peel pack that in the kit itself, there's these three pre-filled syringes. The syringes have sterile, non-preservative saline. And then it has the Rinsada device. And so the Rinsada device itself is single-use plastic. It's disposable because it obviously touches mucosal surfaces. You can't reuse it. And the ports themselves are pretty small. So like what you'll notice is that the design of it's actually kind of cool. And that's a whole other discussion that we can talk about forever. But the design of it's actually pretty cool. And what you do is just you open up the Rinsada device, you get it, and you have everything you need to go. So it's pretty much everything you need. And then usually I like to talk a little bit about spiels because I think everyone has like a spiel when they talk to patients about it. And usually the spiel that I say when I'm talking to a patient about it is, hey, listen, obviously your eyes are bothering you today. Your tear film has infiltrated this really high inflammatory load or really high allergen load. All we're going to do is a treatment today that takes maybe about a minute per eye. During the procedure, your eyes might feel a little bit of tingling underneath the eyelid. That's normal, and tingling a few minutes to hours later. There'll be a lot of fluid that may fall down your face. That's okay as well. And the goal is for obviously you to feel better afterwards. And the results can last, anywhere from a month to 3 months. Sometimes patients don't feel immediate relief. If that's the case, you might just have really high inflammatory load, which may require more than one treatment. Right? And I think that's a fair approach to it. And then otherwise, I'm trying to think what. Oh, and then I guess the other question you asked me, Jessilin, was how to purchase. Listen, we're a huge company. There's so many of us. It gets really tricky.
Do we contact global headquarters or the
Yeah,
US
right.
Oh
headquarters
my
or?
gosh.
We had a change in our C-suite recently, so it's been, kind of up in the. No, I'm just kidding. You go to rinsada.com, www.rinsada.com, and there's like basically a form on there that you can get into, so you can get into our store. Alternatively, you can just call our Rinsada corporate number, which AKA is a Google Voice number that goes to my phone number. Let me find it, and I'd be happy to give you my personal number, but it's also like I don't want patients to find that. That'd be too much. 347-746-7232, which I think it's 347 Rinsada, if I remember correctly. So I was able to get the number correctly, so it's the correct rank, yes.
Spoken like a true entrepreneur.
Yeah,
As
look at
Jackie and I are
that.
both being practice owners, like we totally get that. Sometimes it's like a one-man show, three-man show,
Oh
your
yeah, and
friends and
what I
family are
like.
helping.
Yeah, and I like it. I mean, I think it's definitely been like we kind of started in the beginning. I talk fast and I kind of like the challenge, and I think that all of this has been a challenge. It's very interesting to be on both sides of the coin, right? To be both the practicing physician, but also now to be on the industry side of it, and how the sales, how the sales cycle is, how the purchasing decision happens, like what, every stage or kind of every month is a new challenge. And so, yeah, it's been really fun.
Well, welcome to the front of the eye. It's really fun up
Yeah.
here. We enjoy it at the front. So
It's
welcome to
all
the ocular surface disease space.
great. Well, thank you. I'm glad to be here. I don't know if my exams will ever be different than 1 to 2 plus SPK, but uh, I will try my best. I will try my best. Yeah.
I actually, for our listeners, rinsada.com is actually, it's a phenomenal website. I mean, it has like, it shows the device up close. It shows how it works. There's education videos on there. Like, I think it's really wonderful and really well done. So if our description of it is not good enough for you, go to rinsada.com. You'll see
And
it.
it's really a hard thing to describe,
It
right? Like
is.
it's just it's absolutely bizarre. Like even when people like you don't really get it until you just feel it and use it. Because it's like no matter how much you show it, it's like what is this? Like what is going on? And so I think that that's definitely a trick. The other thing was I forgot to mention to answer your question was that the tips, the practicing tips. We talk about these 3 Ps, and this is actually something that's evolving for our procedures. 3 Ps when you're doing the procedure is pocket, position, and push. So the idea is that you lift the lid against the orbital rim. and then you create a pocket. You put the device underneath the pocket that you create in the right position. So basically, you want to be as close as possible to the plane of the face, so as close as possible to the forehead or the cheek. So forehead when you're doing the upper lid and cheek when you're doing the lower, and then push. So you want to push hard and fast. So actually, during the middle of this podcast, "Push It" by Salt and Pepper came on my headphones and no one else's, but because we're doing this like, promo where I'm trying to figure out the correct timing, but we want to do it so like it lines up to "Push It" by Salt and Pepper because it shouldn't take you longer than like two of those verses to do the whole syringe, right? And so just like the American Heart Association does "Staying Alive," like you're supposed to do CPR to stay alive. Yep. We want to do that same kind of phenomenon, but we don't know the interval yet. But that will be on our website hopefully in a little bit.
That's perfect. And I think I'm glad you touched on that because that was my biggest learning curve is that I wasn't laying the syringe kind of flat enough to the face, which is huge, makes a big difference. But also I wasn't pushing fast enough. Like there's this tendency that you want to kind of baby it along and you're not going to get good results with that. So I'm glad that you pointed out those 3 Ps. I like it.
Yeah. So there's a new video on our YouTube website or YouTube, which I think we have a link to it on our website for that goes over those 3 Ps as well. And hopefully we'll have the Push It stuff out soon in the near future.
Love a little salt and pepper.
Right.
And I
Yeah.
also love hearing our guest's life lens. So, life lens, if you don't know, is kind of this. It can be anything that you want. It can be a product. It can be a motto. It can be a life rule, but something that's been impactful, made your life better. So, what is your life lens? Do you have one?
I do. And, it's going to be very easy. It's, oh, wait, what is this called? Company called? Oh, a thermoflask. I don't think I'm very late to the game, but thermoflask. So I used to always drink water out of Nalgene's, those plastic Nalgene's until like less than a year ago. But then at Costco, they had thermoflasks on sale. And I've heard that they were like, I was like, oh, that might be nice. But I didn't realize that they keep ice cold for so long. Like you can keep ice in there and it stays cold all day. It's really useful for me because I have okay, what do they call it? Primary polydipsia or psychogenic polydipsia, where it's basically you drink too much water. It's like a condition where you just drink water constantly, even though you're not thirsty. I just drink a lot of water. And so I have that, and I love to drink really cold water because I'm always hot. Hot to the point where like I like to keep the office around 65 to 66 degrees, and all my patients are like over 88. They're all freezing,
Oh my
but
gosh.
they're like in like sweaters all the time. I always complain, and I have to have it's like 65, 66, and there has to be fans blowing all the time. Yeah, I get really bored very easily. And so like that's why I don't think so that's why I love the thermoflask because it keeps my ice water cold all day long and I feel cold, which I really like. And so yeah, that's why I don't think I could ever leave like the Northeast either because I would hate like I couldn't live in Florida or somewhere in the South because I'd be so hot all the time. And maybe Maine's my next stop because I can just need to be colder
Yeah,
and colder.
yeah,
Yeah,
go
exactly.
go to Maine, but listen, I'm just gonna advocate for your patients. So now that you have this like hydro flask, and you're colder, can you give these people a degree higher? I mean, this is insane.
Oh
Oh
no, there's
my
nothing
god.
worse. I know, and I'm awful about it. I'm so like this morning, for example, because it's the worst on Monday mornings because obviously the air doesn't run for the weekend. And so I remember my injection assistant texted me, be like, "The air is really warm. Just be warned." And I was like, "If it's too warm, I'm not coming. I'm going to leave." I'm not mean about a lot of things, but the heat is one thing I just cannot stand. I'm usually pretty like, I'm pretty like easygoing about stuff, but being warm when I'm working is just no. So for listeners out there, yeah, thermoflasks are great if you get very hot and want a really cold drink. So
I
there you
like
go.
it. And stylish, great colors, and also
Yes,
fitting because our patients also need to be hydrated in order to
right.
help their ocular surface. So very on
Yes,
brand. I
that is
like
right.
it.
Exactly. Right. See, and you thought I didn't care about the ocular surface. Yeah, and I am all about hydration. Jeez, come on.
It's perfect. It's perfect.
Mhm.
Well, thank you so much for being here. If I know you gave the Rinsada website, but if somebody wanted to connect with you or find you, what's the best way for them to get in touch?
Yeah, no, don't. No, you can definitely email me is totally fine. It's Srini S like Sam R I N like Nancy, I at Rinsada. That's RIN like Nancy, S like Sam, D like David, A.com. I think that'll be the easiest way to reach me. And yeah, I don't have any social media of my own. We have a Rinsada, like, what is that? An Instagram account? It's Rinsada Device. Isn't that called Instagram? Yeah, Rinsada Device. And so I do not run that, but I do check it every once in a while. And so yeah, if you want to reach out to me there, that would work as well.
Thank you so much for being on this podcast. It is always enjoyable talking to you. So I think our listeners are getting a lot of good information. I really appreciate you taking the time.
Oh my gosh, no, thanks for having me. I'm sure that this will be the first and only time that you invite me on. So yeah, I have to take advantage of it when I can.